welcome all to the today's session. We continue with biochemistry module and we begin with our code master MRCOG with concept oriented clarity. So today we will learn about bilirubin metabolism. This is also one of the frequently asked topic in the examination. So let us see the basic concept of this bilirubin metabolism. What we know is it is the end product of heme breakdown. There is no physiological function. It is excreted in the bile. This heme, which is broken down, will form the bilirubin, which has got no physiological function, so it will be excreted in the bile. How much is the daily production? Around 300 milligram per day. 80% is from the old RBC destruction, 10% it is ineffective in erythropoiesis, and 10% from the myoglobin and other heme proteins. This bilirubin is getting formed. So most bilirubin comes from the senescent RBCs. So that is what is the source of bilirubin. Okay, so formation of bilirubin. What are the steps? So heme, which is broken down and gives the biliverdin, which is green in color. This biliverdin is getting converted into the bilirubin, which is yellow in color. The key enzyme which is responsible is a heme oxygenase. Okay, so it requires oxygen and NADPH. It releases carbon monoxide, and that is the unique feature. So biliverdin reductase is required for this. This will convert biliverdin into bilirubin. So biliverdin to bilirubin conversion is via biliverdin reductase. Okay, so CO production is the marker of heme breakdown, and iron is reused via transferase. So once the heme is broken down, iron is used. However, further the bilirubin, initially the biliverdin is formed, then from biliverdin you via the action of the biliverdin reductase you get the bilirubin. Okay, so this is transported in the blood. So bilirubin, initially it is water insoluble. It is transported bound to the albumin, so it binds with the albumin, and then albumin it will get bound, and for one albumin it will have an attachment of two bilirubin molecules, and drugs like aspirin, penicillin can displace this bilirubin. Okay, so displacement in the newborn may lead to the kernicterus also. Okay, then hepatic uptake and conjugation. Now what happens in the liver? This bilirubin will get united with the glucuronic acid, and there will be conjugated bilirubin which is formed. The enzyme which is responsible is a UDP-glucuronyl transferase. This is the enzyme important from SBA point of view. You remember UDP-glucuronyl transferase. So in the liver, bilirubin will combine with the glucuronic acid and will form conjugated bilirubin. The enzyme responsible is UDP-glucuronyl transferase, and 80% is in the diglucuronide format, and 20% is in the monoglucuronide format. Okay, so conjugation makes the bilirubin water soluble, and the drugs inhibiting the conjugation are primaquine, chloramphenicol, androgen, etc. Okay, so next step is the excretion to the bile. So conjugated bilirubin will via bile, that is a AT-dependent transporter, that is MRP2 and MOAT. So rate limiting step here is a excretion into the bile. So this bilirubin which is getting formed, conjugated bilirubin, it will go through the bile. What is the further fate? So in the intestine, this conjugated bilirubin, which is water soluble, again is broken down by the bacteria into urobilinogen. Okay, this urobilinogen is further converted into stercobilinogen, and this stercobilinogen will go excreted via the feces. The total output is around 250 to 300 milligram per day in the feces. Okay, so not only that, there is a enterohepatic circulation. 20% of the urobilinogen. Okay, so this conjugated bilirubin will get converted into the urobilinogen. This urobilinogen, partly 20% will get reabsorbed, and 80% will get formed into the stercobilinogen, which will be excreted, while 20% of the urobilinogen will be reabsorbed and it will return to the liver and it will be re-excreted. Okay, a very small amount is excreted through the urine, less than 4 milligram per day. Okay, so final pigments which are the urobilin and the stercobilin. So urobilin is yellow in color and stercobilin is brown in color. This stercobilin is excreted through the feces while urobilin is excreted through the urine. Okay, so stool color is due to the stercobilin. Okay, that you should remember. Then plasma bilirubin level, total bilirubin is 0.2 to 0.8 milligram per deciliter. Unconjugated is 0.2 to 0.6 milligram per deciliter, and the conjugated is 0 to 0.2 milligram per deciliter. Jaundice, what we say is more than when there is a hyperbilirubinemia, 1 milligram per deciliter, and clinical jaundice is seen when the level exceeds more than 2 milligram per deciliter. Okay, so which test is used for detection of this bilirubin? It is the von Denberg test. Okay, von Denberg test. So we know that the bilirubin is a conjugated as well as unconjugated bilirubin. This only conjugated bilirubin will give direct positive, while unconjugated bilirubin will give indirect positive test. That means the test will be positive after addition of alcohol, while this conjugated bilirubin will give the direct positive test. Okay, so water soluble will give direct reaction. Okay, so what are the features of the unconjugated and the conjugated bilirubin? Unconjugated bilirubin is water insoluble, it is bound to the albumin, it is absent in the urine, it can go into the tissues, and Vandenberg is indirectly positive. Well, conjugated bilirubin is water soluble, it is not bound to the albumin, it may be present in the urine, there is no tissue diffusion, but the Vandenberg stress is directly positive. Okay, so kernicterus is because of the increased unconjugated bilirubin in the neonates. Alcohol and drugs affect conjugation. Antibiotics will reduce the drug flora and may lead to the green stool because of the biliverdin. Okay, so heme is converted into biliverdin and finally into the bilirubin. Unconjugated bilirubin is albumin bound and insoluble, while conjugated bilirubin is water soluble, excreted in the bile. Rate limiting step is a biliary excretion. Okay, stool color is because of the stercobilinogen or stercobilin, and Vanderberg test is a direct versus indirect. So direct will be positive for conjugated, indirect will be positive for unconjugated. Okay, so that finishes the bilirubin metabolism. Doctor, can you read a few questions here?
Yes, sir. A 40-year-old patient has increased bilirubin production. What is the most common source of bilirubin in the body? Myoglobin breakdown, dietary, heme, senescent red blood cells, liver cell metabolism, and muscle protein. Sir, option C, red blood cells.
What is the option? Answer?
Option C, red blood cells.
Option C.
C.
Okay, senescent RBCs. 80% bilirubin is derived from breakdown of old RBCs. Remaining 10% is from ineffective erythropoiesis and 10% from other heme proteins. So most bilirubin is because of the RBC destruction. Next.
Which enzyme is responsible for converting heme to biliverdin? Biliverdin reductase, heme oxygenase, catalase, peroxidase, cytochrome oxidase. Also biliverdin reductase. Option A.
Option?
A, sir.
Is it A? B. Option B. Heme oxygenase, because you are getting it from heme, no? Heme oxygenase. It requires oxygen and NADPH. It produces biliverdin plus CO. CO production is unique feature. CO production is equal to marker of heme breakdown. Okay, next.
Unconjugated bilirubin is transported in plasma primarily by which of the following? Unconjugated bilirubin is transported in plasma primarily by which of the following? Hemoglobin, transferrin, albumin, globulin, or lipoprotein. Sir, option C, albumin. It's conjugated.
Stop, Alexa. Yes,
Albumin,
option.
sir, option C.
Option.
C. It's conjugated.
Yes, option C. Okay, so it binds with albumin. Unconjugated bilirubin is water insoluble, bound to albumin for transport. Drugs may displace bilirubin. There is a risk of kernicterus in the neonates. Next.
Which of the following represents the rate limiting step in bilirubin metabolism? Sir, option E, formation of urobilinogen. Option E.
Option,
E.
it is option D,
Option
excretion
D,
into the
D,
bile. Okay,
excretion into bile.
excretion into
Yes,
the
the last
bile,
one.
active transport via MRP2 or MOAT. It requires ATP. This is the slowest and
Great.
rate limiting step. Next.
A patient's bilirubin gives an immediate positive reaction with diazo reagent. Which form of bilirubin is present? Sir, option C, conjugated bilirubin.
Immediate positive reaction.
Is conjugated. Oh. Option C, sir.
So answer is
Option.
option C, conjugated bilirubin. Okay, so conjugated
Yes.
bilirubin is water soluble. It gives direct test positive. Unconjugated requires alcohol. That is an indirect reaction. So direct is will or conjugated will give direct test positive. Next.
A patient on prolonged antibiotic therapy develops pale or greenish stool. What is the most likely reason? Increased bilirubin production, increased tocopherolin formation, reduced intestinal bacterial conversion of bilirubin, or increased urobilinogen excretion, or increased bile secretion. Sir, option C, reduced intestinal bacterial conversion
So
of
answer is
bilirubin.
option C, intestinal bacterial conversion of the reduced intestinal bacterial conversion to bilirubin. So antibiotic will reduce the gut flora. There will be decreased conversion to urobilinogen and stercobilinogen. Bilirubin is oxidized to biliverdin and that will give the green stool. Okay. So important things are 80% bilirubin comes from the RBC breakdown. Heme oxygenase will lead to CO release. Unconjugated bilirubin is albumin bound. Rate limiting step is the biliary excretion. Direct reaction is the conjugated bilirubin and stool color is positive because of the stercobilin. Okay.